right. The pathologist calls you and says the P16 on the histology is positive. What does that mean for the patient?
And likely it means that there's, that's evading me right now, but it's HPV virus involvement.
Okay. So scenario 1, your staging workup shows that there are multiple bilateral liver lesions suspicious for MET. How do you treat that?
Sure. So I would have her referred to both radiation oncology and medical oncology. And in this case, considering she has evidence of metastatic stage 4 disease, I'd recommend neoadjuvant chemotherapy. There are checkpoint inhibitors that can benefit her in this case.
Okay, scenario number 2.
Could I ask how old did you say the patient was?
She is 60.
Okay.
Mm-hmm. Scenario number 2, your staging shows that she's a clinical T2N0M0, so she's a stage 2.
Yeah, so in that case of stage 2, I would recommend that she undergo neoadjuvant curative intent chemoradiotherapy with 5-FU, mitomycin C, and 54 gray of radiation.
Okay. What's that protocol called?
NIGRO protocol.
Okay, so she receives that, and then she comes to see you in the office 5 weeks later, and the lesion's still there. It's slightly reduced in size.
So I'm seeing her 5 weeks post-treatment.
Mm-hmm.
Okay, so I reassure her. I tell her that she's undergone all the normal therapy, but we would like to wait at least 3 to 6 months in a lot of cases to make sure that she has a response. So I see her again at 3 months.
Okay, so you see her in 3 months and the mass is completely gone, but there's a scar. What else do you want to know?
Okay. Is there any nodularity to the scar? Is she have any residual inguinal nodes or new inguinal nodes?
Lymph nodes are
I'd
negative.
ask her about her bowel function as well.
She has good continence, and there's no nodularity. It's a flat scar. Do you want to biopsy the scar?
No, I would not biopsy the scar.
Okay. What's your surveillance protocol from here?
Yeah, so I would make sure that she underwent staging scans, so MRI of the pelvis, CT, abdomen, chest and abdomen at 6 months. I would perform an anoscopy, I would be able to do a flexible sigmoidoscopy every 3 months, as well as a clinical exam and seeing me in the office, and the CEA every 6 months.
All right, so let's say at the 3-month mark after NIGRO protocol, you see that the mass is still there, but it's decreased in size to 2 centimeters.
So she had a response, and now she's having regrowth?
No, we're kind of resetting this. I'm giving you a couple of different.
Oh, I gotcha.
Yeah.
Okay.
So let's say instead at the 3-month mark, the mass is still there, but it's slightly decreased.
Okay. I would tell her that she's had a partial response, and I would see her at 6 months.
All right, so you give her 6 months to respond. It's now 6 months. The mass is still present. In fact, you think it's growing a little bit.
Okay. So I tell her that she hasn't had a full response from curative intent chemoradiotherapy, and I recommend undergoing an APR.
All right. Anything you want to do before doing the salvage APR?
So I would do, I'd restage her. So since it's been 6 months from therapy, she needs a CT scan of her chest, abdomen, and pelvis, MRI pelvis, to make sure that she hasn't developed new metastatic lesions, which would potentially put her onto a chemotherapy type protocol. And then if that's all negative, I refer her to plastics for flap reconstruction, as well as anerostomal therapy for preoperative education and teaching.
All right. So let's completely backtrack and say that she did have successful NIGRO protocol, so she did not require any surgery at all, and she's undergoing routine surveillance with you. She's in your office about 1 year later, and you detect new inguinal adenopathy on the left side.
And at that point, she would have had scans. Do the scans show new inguinal adenopathy?
Yes.
Okay. So I refer her to interventional radiology for biopsy of these inguinal nodes.
That's positive for metachronous inguinal mets.
Okay. And what about her anorectal exam? She had still no evidence of these disease on anorectal exam.
All right, so the primary site is negative for recurrence.
Okay, so I would refer her to um, to medical oncology for chemotherapy.
Okay. Um, anything else that you can do?
So in the case of squamous, does she have unilateral or bilateral disease?
She has unilateral.
Okay, and at that point, since she has evidence of cancer in that one node, I would have her undergo PET-CT, make sure she doesn't have any other metastatic lesions.
It's isolated to the left groin.
Okay, so she could undergo left inguinal basin harvest. So I'd refer her to a surgical oncologist who's
Okay.
trained in that.
Let's say that she does have this inguinal adenopathy, PET and biopsy positive, and there's recurrence at the primary site as well. Remember, you never operated on her.
Right. Um, so she has inguinal and primary disease, and then no disease anywhere else.
Correct.
So I refer to, I would offer her APR and inguinal node dissection.
Okay, next case, 40-year-old female. She presents complaining of stool and pus draining from the vagina and some foul odor. She feels this on and off low grade fever and pain in the perineum. She has a history of a perianal abscess that was about 2 years ago. They treated that with incision and drainage, and she thinks that completely resolved. She has had no other procedures to the anus. There are no urinary symptoms. What else do you want to know?
Okay, so I asked her also about abdominal pain. I'm thinking that she could either have a perianal abscess or rectovaginal fistula, but she could also, if she has had a history of a hysterectomy, she could have diverticulitis with a high colovaginal fistula.
No abdominal pain.
Okay. What about surgical history?
She's had that prior IND and she had a cervical cone biopsy.
Okay. Was that recent?
That was 3 years ago.
Okay. So then I also asked her about um, her sexual habits as well as a little bit more about the drainage that she has.
The drainage is consistent. She's married, one partner, monogamous, uses protection. She had 3 vaginal deliveries with no trauma that she can recall, and she's a chronic smoker.
Okay. I do a vaginal and an anorectal exam in the office.
All right, so on examination, her temperature is 100.4, pulse is 90. She has a small amount of pus and stool draining from the vagina. There are no discrete external lesions. The sphincter tone feels normal. Bimanual exam shows that there's no palpable defect in the rectal vaginal septum, but there is some tenderness there. Otherwise, you're unable to complete an anoscopy or speculum exam. You're suspicious of a rectal vaginal fistula. How would you confirm that diagnosis?
Well, in this case, it sounds like she may have evidence of undrained sepsis. And so I'm kind of worried that she has some kind of abscess, either high suprasphincteric or infrasphincteric, if there's nothing evident on exam. So I would get a CT scan of the pelvis with ID contrast.
Okay. The CT shows some induration in that rectovaginal septum and possibly a submucosal collection, but no masses or other collections.
Okay. So there's nothing really drainable that's on exam or on the CT scan.
No, but she's has a low grade temperature and she's uncomfortable.
Okay. So in the office, confirmation of a low rectovaginal fistula. What I would do is I'd place a clean tampon in the vagina, and then I would use either methylene blue or betadine in the rectum, and then I have the patient walk around a little bit, and then I check the tampon for any evidence of methylene blue or betadine.
Okay. Okay, great idea, but she's unable to tolerate.
So then I offer her and I recommend examination under anesthesia in the operating room.
All right, so you take the patient to the OR, and what are the specific things that you want to evaluate and do during that case?
As I want to do first um, very thorough vaginal exam. So she's having tenderness in the rectovaginal septum, and the CT scan seems to indicate fluid. I would look at that. I would also do an anorectal exam, anoscopy, look for distal proctitis as well as any evidence of an internal opening consistent with a fistula or an abscess, and drain it if I found that.
Okay, so you find a low rectal vaginal fistula with a zero point 0.4 centimeter opening just proximal to the dentate line. There's inflammation in that rectal vaginal septum, and you unroofed a small submucosal abscess and you placed a draining seton. The rectal mucosa appears normal, there's no proctitis, no stricture, and you biopsied the fistula tract. It shows chronic inflammation. Patient improves after her procedure. When do you want to see her again?
So I would see her a few weeks after to make sure that she doesn't, or at least 2 weeks after to make sure that she doesn't have a recurrence of an abscess.
All right, so you see her, she's happy with the improvement, but she wants a seton out. What do you advise?
Yeah. Well, I'd do an exam in the office if she can tolerate it. If she has a very, very short tract, if the tract seems like it's developing, I'd recommend that she keep it in for 3 months so that the tract can develop. And if she can deal with that at that time, I would offer taking it out at 3 months.
Okay, so you see her at 3 months, and the it's soft, supple. There's no infection. The tract you think is well formed, but it's still widely open. The seton is moving, spinning all around, and she wants her surgery.
Okay. So if it's been at least 3 months, if all the inflammation has died down, um, I'd offer her a definitive surgery to try to treat this. I guess the question that I would have would be on exam, does it look like she has an intact sphincter complex?
Yeah, it feels intact. She has good tone, and she also wants to know if she's fully optimized for her surgery.
Oh, she's a smoker, correct?
Yeah.
So I recommend that she stop smoking. And then, um,
Okay, so she stopped smoking and she's set, you're set. What she has a low fistula. What repair options are you offering her?
yeah, so I think I would first start with an endorectal advancement flap.
Okay. Can you describe how you do that?
Sure. So I would do this in prone position. The patient would be under general anesthesia. I would do again a thorough vaginal and anorectal exam, make sure she doesn't have distal proctitis. I would incise. Well, I'd mark out my flap first. So I find the fistula tract. If she still has the seton in, I would go a little bit past the dentate line, usually right at the anal verge, mark out several centimeters, and then a trapezoidal shape submucosal flap. Um, and then I'd use saline injection to raise the flap. I'd use electrocautery to then lift that away from the muscularis. I'd take the seton out. I'd clean up the flap to make sure that the fistula had been excised on the rectal side. I debride the small short tract in the rectovaginal septum. I use an ovicle UR6 to close the muscularis portion of the tract in the rectovaginal septum, and then I advance the flap and I use that to cover the defect.
Okay. Are there any operative principles that you follow to ensure that your flap does not necrose?
Making sure that you don't uh, taking great care to make sure that the flap is completely intact. You don't cut through the flap at any point, and raising submucosa.
Okay. Any other options that you can offer her instead of the endorectal advancement flap?
Sure. So the other option would be, especially if she had any evidence of sphincter defect with her obstetric history, would be transperineal repair with an overlapping sphincteroplasty.
Okay, awesome. Let's say if she had a history of radiation therapy for cervical cancer and you found this low-lying fistula, same area, but she had a very thin rectovaginal septum and she didn't have a lot of native tissue in the perineum. You tried an ERAF before and it failed. What can you do?
Yeah, in this case, the flap coverage is going to be more important for her. So if she's had radiation to the perineum, I would not consider a Mardius flap, considering the local radiation. So I would have a plastic surgeon help with the gracilis flap, and so then I would do a transperineal overlapping sphincteroplasty repair with gracilis flap in between.
All right. Let's say that she had a history of Crohn's disease and she had a watering can perineum and she has multiple complex fistula on examination.
Mhm. How well controlled is her Crohn's disease from a medical
She's
perspective?
not on any medication.
Okay, so I refer her first to GI um, for treatment of her medical Crohn's disease. She needs to be on a biologic as well as potentially azathioprine. And then if she's having very, very significant perineal symptoms, as I suppose she may be, I also offer the fecal diversion.
Okay. Fecal diversion is done. GI, I think she's totally maxed out on medical therapy. She has active inflammation and local sepsis.
So she has local sepsis. So I drain the sepsis first.
Hmm. Anything definitive that you can offer her?
Yeah. So in this case, I would tell her that if she were to undergo a restoration of intestinal continuity, that she would likely have the same problems. And so I would recommend that she would have proctectomy with flap reconstruction.
Okay. So let's say her Crohn's was very well controlled and you scoped her and there's no active proctitis. She has a single, simple, low-lying rectovaginal fistula with a well-formed tract.
Okay. Is she having significant sepsis, or
No,
what kind of symptoms is she having with the
she still has, she has some foul odor and she sees some fecal drainage and it bothers her psychologically.
okay. While she's well controlled on Crohn's disease, then I would offer her repair the fistula. And so I think I would do similar to the first scenario. I would try an rectal advancement flap if she had no evidence of distal proctitis.
Okay, let's go back to the initial presentation. When you examined her in the OR, you found a high fistula, which you think is a colovaginal fistula confirmed on imaging.
Is
How would
this
you
that?
approach that? This
And
is
this is
not
a
a Crohn's
Crohn's.
patient. This is the 40-year-old female who just showed up in your office.
Okay. And then was this the similar obstetric history?
She has, yeah, similar obstetric issue.
Okay. I would get a CT scan and check for any evidence of diverticulitis with colovaginal fistula.
Okay, and you think she has a colovaginal fistula secondary to diverticulitis? How would you treat?
Primarily, I would take out the diverticulitis. So I would offer her robotic low anterior section, sigmoidectomy with primary anastomosis, making sure to disconnect the fistula, and in the process of doing a reconnection, make sure that the vagina is well away.
Okay, how do you think you did?
I miffed Paget's.
I think you did a great job, actually. I think you have a great knowledge base and you had very good eloquence as well.
Thanks.
You were confident and your pace it wasn't too slow, but you weren't just overly jumpy. I really like that. I think you have a good approach. The one thing I will say is that I know when you don't really know things, when you're unsure, you have a little bit of a tell or you get a little uncomfortable. So
Sure.
I want you to keep that confidence going because you actually have a good knowledge base. Okay. I like it that you did your rigid procto when we're looking at the pruritus ani person to rule out any proctitis for that. I just want to see you flesh out the causes of the pruritus ani a little bit more. Kind of asked you for that twice, but if you say at least 5 things, I think they'll kind of move on and leave you alone.
When you say the causes, do you mean like Dietary irritants.
Yeah, medications,
Okay.
psychological issues, the dermatoses, the STI, non-STI infectious causes,
Okay.
like the
Sure. I
systemic
gotcha.
diseases. Yeah. Uh, what else? When you excise the Pagets, you can consider rotational flap or split thickness skin graft for the
Okay.
closure. And the one I think that tripped you up a little bit was when we found the rectal mass as well as the Pagets. The thing that they want you to say is an APR for that case, because the Pagets can spread like subepithelially. So just consider them to be connected,
Sure.
basically. All right. The other options for the Pagets you mentioned, imiquimod. There's also laser therapy, radiation, chemotherapy are options. The P16, good associated with HPV, and it's also a better prognostic factor for the patient. When we did the 6 month eval and the mass was still present and we're getting ready to do our salvage APR, just don't forget to always just restage before you intervene on any patient. Um, and then, yeah, so I think that case went well. And the rectovaginal fistula as well went well. When you do your flap, the base has to be that much wider than the apex just to make sure that you don't have any necrosis to the flap. And don't forget that you can repair these transvaginally. It's not ideal because it's not the high pressure side, but in the exam they just want to know that you know all these other things.
Right.
Yeah, but I think you made a great call with asking about her sphincter status, because it actually was going to give you grade 4 obstetric injury um, that was coming back at 3 months, and you were going to wait 6 months and then do that whole episioproctotomy. So I think you hit the nail right on the head. So great job. The cervical cancer patient who had the radiation, just make sure you take biopsies to make sure that there's not recurrent cancer in that area. All right.
Right.
But other than that, it was a clear pass for me. Rob, do you have any critiques or comments?
You guys covered a lot of ground. That was like,
Yeah, I think I stole some of your time too.
no, it's fine. That was fantastic. And like, it is challenging to like swap up scenarios. They do that on the boards though, not as aggressively, but they will
Right.
have like, okay, let's go back and let's say this is a 4-year-old with X, especially in the rectal stuff. In my experience, that was definitely true where they would jump. I didn't experience that with general surgery boards as much. I felt like general surgery boards was much more scripted, and the
Right.
colorectal boards is a little more flexible. So, having that flexibility is great, and you definitely have it. Your body language is good. Your ability to roll with the punches was good. Obviously it's a challenge to reset the scenario in your head and then catch all the things that you need to catch.
Right.
Pretty good job. I mean, there was very few times when I was like, oh, like that would be a little bit different, uh, and nothing that would have been huge. You caught yourself.
Yeah.
Christine did prompt you nicely. She was very kind as an examiner. Like if she thought you were definitely missing yourself there, she would grab you and head you in the right direction. So they're not going to do that on the actual boards.
Right.
But other than that, no, fantastic. And I think that there was nothing that that I would change in either scenario. And those are tough scenarios. And there's like 5 scenarios in there that you covered. So your knowledge base is great.
Yeah, don't beat up on yourself at the end of the day too, because you always do better than you think. Everybody
Sure.
thinks they fail or they, did horribly, but
I,
it's not the case.
I
Good
think
job.
this is probably worse because I'm in front of all my peers. I don't think none of my peers are going to be watching me,
So true.
flub this.
So true.
My
Yeah, that's
co-fellows.
absolutely true. That's yeah. So yeah, and the examiners are rooting for you. I said they're not going to give it to you, but the examiners really are rooting to you. They want you to become part of this community. They want you to pass, and so they're just making sure you're not going to do something truly insane or miss something
Right.
huge.
Right.
And so along those lines, if you do feel like you're getting down the line of the question and oh man, I forgot to get a cola, you absolutely can go back and be like, you know what? At the beginning of the scenario, I forgot to get a colonoscopy. I would definitely make sure this patient had a colonoscopy. And it's inelegant, but it's definitely going to get you what you need. And honestly, I have done that in practice where I have called a patient and been like, I've been thinking about your case and I think you need a colonoscopy. So that is totally reasonable. So yeah, all those things were really great. All right. Callie, it's you and me, and we're going to go fast. You ready?
Yes.
Okay. So this is a 63-year-old woman complaining of constipation for several years duration. She feels like stool drops down into her rectum, but she can't push it out. It's gradually gotten worse over the years. It's associated with gassiness and bloating, and then tenderness over the left lower quadrant. She takes a bowel regimen. If she doesn't take a bowel regimen, she says you probably wouldn't have a bowel movement at all, maybe one a week. She can't live like this anymore, and she's here in your office. What do you want to do?
Okay. For the 63-year-old female with a several-year history of worsening constipation, it sounds like she does have sensation of the rectal vault, feels like she needs to evacuate, but has a sensation of incomplete evacuation. So as part of my focused history and physical exam, I would specifically evaluate for any history of diverticular disease, any history of GI tumors, any relevant family history. I would get into her previous endoscopies, see when her last colonoscopy was. I would also ask an obstetric history and evaluate her continence, given that there could be a chance of pelvic floor dysfunction or obstructive defecation. And I would perform my anorectal exam, including an evaluation of the perineum.
Okay. So family history is negative for IBD or colon cancer. Her last colonoscopy was 1 year ago, and she says it was fine, except that the endoscopist told her she had a twisty, redundant colon. She has had 2 vaginal births, no complications with either one. She has a history of a hysterectomy for disordered bleeding about 15 years ago. Remind me again what else you're looking for in history?
Prior diagnoses of diverticular disease. I think you covered what I needed to know.
No actual history of diverticular disease in the past.
Okay, great. So my differential for this patient includes slow transit constipation, pelvic floor difficulty, including obstructive defecation, the possibility of a rectocele. So I would perform my anoscopy, my digital rectal exam, evaluate her sphincter function and squeeze, and look at the perineal body.
So you perform a in-office exam. It shows a normal, slightly diminished sphincter tone at rest, but squeeze feels grossly normal. When straining, there is palpable pelvic floor descent, and you can feel billowing of tissue at your fingertips. There is a grade 2 to potentially even 3 anterior rectocele, non-tender with palpation of the anorectal ring with no pressure points. The vaginal exam shows what you think may be a palpable enterocele.
Okay. So based on these findings, it sounds like she probably has an enterocele and some difficulty with evacuation secondary to pelvic floor dysfunction. I would make sure that she is on a bowel regimen, including 30 grams of fiber daily and Miralax daily, and adequate water intake. I would send her to pelvic floor physical therapy for 6 to 8 weeks to try to address this.
Okay, so she is actually already taking Miralax twice daily, Colase 3 times daily. She takes magnesium citrate twice a week, and Amitiza daily. So she's already on that as a bowel regimen before she saw you. You added nothing to that, right?
Correct.
Okay. And then she went to biofeedback for pelvic floor therapy. She completes that. She returns to your office and reports no change.
No improvement. I would obtain MR defecography in order to evaluate this procedentia.
So her defecography reveals a moderate anterior rectocele with rectal intussusception, the superior margin of the rectal seal, greater than 4 centimeters below the PCL for pelvic floor descent when straining, incomplete rectal emptying, and persistent incomplete straightening of the anorectal angle will strain. And she's positive for enterosil.
Okay. Yeah, this represents dual compartment precedentia with resulting obstructive defecation. So I would discuss the case with my GYN colleagues and see if we can arrange a joint procedure to address both her anterior and posterior compartment precedentia. That would take the form of a robotic suture rectopexy on my part and the vaginal sling for the gyne portion before proceeding to the operating room. She has had a colonoscopy within the last year, so I don't need to repeat that, but I would specifically evaluate for urinary symptoms, any difficulty with bladder emptying.
No urinary symptoms. Your urogynecologist is very excited to work with you. Find a good operative date. You perform the procedure. How would you do it? So you said robotically and a posterior suture rectopexy?
Yes, I would do a robotic posterior suture rectopexy.
Tell me the steps.
I would obtain access to the abdomen, place the patient in lithotomy. After obtaining access to the abdomen, I would dissect the posterior aspect of the rectum in my typical TME plane. I would raise two sort of mesorectal flaps that will be my suture rectopexy sites, and I would secure the rectum in 3 places using ethmoid suture. Stitch that rectum so that it lies straight without tension, and then allow my urogynecologic colleagues to perform their anterior repair.
Would you dissect anterior to the rectum?
I would dissect anterior to the rectum, yes.
Would you dissect on both sides or just one?
I would dissect on both sides. I would caution the patient that that can lead to an increased risk of constipation post-operatively, and I fully expect that she will need to maintain her current bowel regimen post-op. My goal is to relieve her obstructed defecation, but she will likely still have some constipation issues, and she will likely never be off of a bowel regimen medication.
She recovers surgically very well. For about 3 months, she experiences improvement in her symptoms. And then at 4 months returns with increased constipation, which you had warned her about. You dial up the bowel regimen and cycle through additional medications. She's persistently on Miralax, persistently on Colace. She takes magnesium citrate now 3 times a week. She has 1 bowel movement a week. And her constipation continues to worsen. What's the next step?
As she has essentially failed medical management, I would refer her back to pelvic floor physical therapy if we ever cease that, and make sure that we're doing everything we can to alleviate her obstructive defecation. I would counsel the patient that if none of this is productive, there is a chance that she may benefit from a stoma. Just because her constipation is making her this miserable, it's possible that a diverting stoma would increase her quality of life. So that's the next thing that I would discuss with her.
Okay. You complete her second course of biofeedback. She returns. She has marked improvement. Next scenario.
Yes.
All right. This is a 56-year-old obese male with a distal sigmoid mass that was discovered on routine screening by your GI colleague and referred to you from the gastroenterologist. The lesion was biopsied and is moderately differentiated adenocarcinoma, described at 20 centimeters from the anal verge and tattooed distally.
Excellent. Okay. So we have a 50-year-old male with a past medical history of obesity and a newly diagnosed adenocarcinoma of the sigmoid. As part of my focused history and physical in the clinic, I would specifically evaluate for any past medical history that may complicate his operative candidacy. I would evaluate for any family history of IBD or GI tumors. I would also go over his pathology report. I know it's moderately differentiated adenocarcinoma, but I would want to know mismatch repair and MSI as well. As part of my physical exam, I will examine his abdomen and do a digital rectal exam, anoscopy, and rigid proctoscopy in the office to confirm that this lesion is not visible on proctor.
Okay. So he has no family history of rectal or colon cancer, no previous history of polyps or large polyps in his family. His only other medical history besides obesity is hypertension. He takes metoprolol for that. This was his first colonoscopy. And he has no previous surgical history either. Is there anything else on history you wanted?
If he was a smoker.
He's not a smoker.
Great.
On physical exam, his BMI is 45. His abdomen is non-tender, it's non-distended, no scars. Anorectal exam is normal. DRE shows good tone and no palpable mass. You perform a rigid proctoscopy to 12 centimeters and can see no mass.
Okay.
If you can't progress past there, some liquid stool.
Okay, no problem. I would proceed with staging this adenocarcinoma. So he needs a CBC, BMP, LFTs, CEA, and a CT scan of the chest, abdomen, and pelvis with contrast. I would also, he's had his colonoscopy, he has his tissue biopsy. I would make sure we got that MMR and MSI.
Yes. So his CEA is 3.4. His CT shows no metastatic disease. They cannot see the mass exactly. He has MMR is intact. MSI is low.
Okay. This completes my preoperative workup for him. I would counsel him if it's possible for him to lose weight preoperatively. That would decrease his operative risk. I understand that that may not be possible for him, and our priority is performing an adequate oncologic resection for him without unnecessary time delay. So I would schedule him for a laparoscopic low anterior resection.
How would you do it? You said laparoscopically. Take me through the steps.
Yes, I would position the patient in lithotomy, gain access to the abdomen. I perform an initial high ligation of the IMA. I make sure to identify and preserve the ureter at that time. I access the IMA pedicle at the level of sacral promontory, ligate the IMA, use my energy device, and then mobilize the left colon at the white line of Tolt. I would take down the splenic flexure routinely. I identify my proximal and distal transection points. I would make sure that my distal transection point was greater than 5 centimeters margin from that distal tattoo of the lesion. Before proceeding with any resection, I would have evaluated the entire intraperitoneal cavity, looking at the liver to rule out any metastatic disease or peritoneal implants. I transect the specimen, I extract through a fan and still incision, and then I create a stapled EEA anastomosis. I hand sew the anvil and then create a stapled anastomosis and leak test that. As long as there's no leak evident, I don't feel the patient needs to be proximally diverted with a diverting loop ileostomy.
Great. So in the process of this performance, the splenic flexure is a challenge. It's tucked up under the spleen. He has significant intra-abdominal fat. You do complete the splenic flexure eventually. You additionally find that this mass is not exactly a 20. It's more like a 12, 13, probably right where your stool was hiding it from you. Still, you're able to complete your low anterior resection. You were prepared for that. You get below it 2 centimeters. Now you're in the mid-rectum or so. But you still have plenty of stump left, at least by estimate intraoperatively. You perform your high ligation. The rest of it seems to go well. You identify the left ureter. You staple, and as you take your specimen out, the stump will not reach. You cannot get your conduit down to your rectal stump.
Okay. In this event, my first step is to re-examine my splenic flexure mobilization, make sure that I have truly taken all of the gastrocolic attachments all the way to the mid-transverse colon. I can also take that dissection a little more proximally along the transverse colon, try to get more length that way. I will have taken down any omental adhesions that might be producing tension. I will also additionally mobilize my rectal stump to see if I can straighten that out and get any length on the distal end. I'll make sure that my left colon is fully mobilized off of gerotas in the retroperitoneum and reaches all the way to the midline, and see if that helps me.
So you completely medialize this colon. You successfully get it all out of the leftover quadrant. You enter the lesser sac. You take the greater omentum off the anterior aspect. You can fold this thing to the belly button and past. It still doesn't reach.
My next steps from there are to divide the left mesocolon at kind of the bare area, just at the midline. You can usually do that without taking any vessels. Try to divide that all the way up to the level of the duodenum. I would perform a high ligation of the IMV at the inferior aspect of the pancreas. I will also take down the ligament of Treitz to see if that gives me any additional length, and see if that does the trick.
So you perform that maneuver, you divide the IMV at that level, and indeed the conduit now reaches the rectal stump. Unfortunately, it appears ischemic. And on evaluation, it appears that the marginal artery was injured in the process of mobilization, and there's a significant portion of your conduit that is now ischemic.
Okay. In that unfortunate event, I would evaluate the colon to see where the area of viability is. There should be a transition point where I can identify that the colon is viable. And at this point, I have a couple of options. I can perform a retroileal window to try to make it reach. I can, in that case, I would need to convert to an open procedure. My priority at this time is performing an oncologic resection. So I think I have done that. And in lieu of calling in a more senior partner to try to do a retroileal window to make this reach, I would instead create an end colostomy at the area of the viable colon, so that I have the specimen out, can review the final pathology, and I'm not, if the patient is going to need postoperative chemotherapy, I would hate to delay his progress to chemo with an anastomotic complication. So I would create an end colostomy in this situation and try to restore intestinal continuity at a later date.
Perfect. Okay. How do you think you did? We have negative 1 minute.
Sorry. I think it was okay. I tried to. I hope I didn't run over anything. I tend to spit out a lot of verbiage at one time, and I didn't know if that was problematic.
No, I think so. I do like that you measure yourself, because it does let you control the pace of it. That can be, I think, annoying to some examiners, but it's really useful for, I think, examinees to check themselves to make sure that they have all the information. And it also gives you a chance to verbalize what you're thinking with differentials, which is what they're looking for, really. Like, these are my options. This is what I would choose to do, and the reasoning for doing it. So that was, I think, fantastic. That's really good. Knowledge base is great. I think you're absolutely correct. We didn't have a chance to flesh out necessarily additional options, but there are additional options in both scenarios. And you knew your complications that were going to occur from your sutured rectopexy anyway. You knew her constipation was going to get worse, so you told her it was going to happen, and it did happen. So yeah, so I think that all of that went really well. As far as the intraoperative issues with the colon cancer, well worked up, appropriately done. Surgical approach was correct. I want to say that I love this scenario because you think you're doing a cancer, but you're not. You're doing an intraoperative complication scenario. And so you get to the intraoperative complications and you're like, man, I supposed to screwed up horribly earlier on. You did not. You didn't screw up. You are fine. They just want to get you through a relatively straightforward colon cancer so you can get to intraoperative problems. And so if you are running into intraoperative problems, it doesn't mean that that you messed up the scenario earlier at all. It could just totally be that this is what the scenario is about. So in this scenario, they do want you to do something that's not a colostomy. But your reasoning was outstanding. I think you're absolutely correct. So I don't know what they would do with that. I think the examiners would certainly give you a lot of points because that reasoning is sound, that you want to get that person to chemo. But they are looking for you to do something that's not a colostomy. So either a retroileal window, which you named, or a right colonic turn down, or a subtotal colectomy and ileorectal anastomosis, but it's mid-rectal, so that's going to be a big deal. So something, though, has to, they want that something done for it. And I guess maybe the scenario would be better if he told you out of the gate that he refuses colostomy, would never get colostomy, blah, 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 and then you'd be stuck. So, and if we had a little more time, you could tell, you could be like, oh, but the patient said you never wanted a colostomy, and that's how. And then you'd have to choose something that you're going to do, but you already named it, so you have to know something that you would do in that scenario if that were to happen to you.
Okay.
And all the maneuvers to mobilize it were exactly right. So, so that was really good. So I would say it's a pass. The intraoperative issues does want you to do something. That's sort of like one of their key things. But so maybe a provisional pass for that scenario. But for the constipation for obstructive defecation, nice job. Good on you. I don't know if Christine has additional comments.
I think you did a great job. I think your body language was great, and you spoke very clearly, and the content of what you were saying was very good. I don't know that I'm a big fan of summarizing right out the gate as soon as they give you the scenario. It might rub some examiners the wrong way, but if it helps you, then it helps you. Like you got to pass your boards. I really, really loved when you explained why you were doing the colostomy. That was just on point. And I think that initially one would want to kind of fail you a little bit for that scenario, but you explaining it, you're like, yeah, that makes sense. Okay, yeah, you've got your priorities in order. So I think you did a great job.
Thank you. Thanks for your time.
Awesome.
All right. Well, I just want to thank the examiners and the examinees. You guys all did a great job. I think this was probably very helpful. I also want to thank the ASCRS Young Surgeons Committee for kind of helping us arrange this. And yeah, if there are any questions, we have -5 minutes. So we don't actually have any questions in the chat. So, but the recordings will be available. Okay. So everybody have a good night.
Thanks so much.
Okay, take care.
So I had a quick question.
Yeah, of course.
Sorry, I was just wondering, with regards to saying a robotic, are we at a point now where that would be okay, acceptable, or should we leave the robot?
Sorry, you were a little bit auto-tuned there, but I think the question was, is it okay to talk about a robotic approach for your surgeries? Is that correct?
She says yes.
Yes, I see it there. Yes, I think it's absolutely reasonable, whatever way you're comfortable with. One of the things about the colorectal boards that is great is that it is when you've been in practice for a little while, so you're all will be successful survivors of the general surgery boards. You'll have passed your writtens for colorectal, so your knowledge base is good, and you'll have been in practice. So you know what? If you do robotic resections, you're just going to walk through this case like you would walk through this case if you were sweating it out in the operating room for real. So if your usual approach is going to be a robotic approach, then you should definitely talk about a robotic approach. I think the key is you just want to be comfortable with whatever approach you describe. So your key steps, you can summarize them very, very quickly. You can talk about, the key things that you're going to watch out for, the landmarks, how you're going to do it. That's it. So yeah, I absolutely think so. I think we're at a point where a robotic approach would be just fine. Or a laparoscopic approach for a rectal resection also is reasonable. The guidelines basically say you should use it with caution, but it doesn't say you can't. So
Joel has one quick question, if you guys don't mind.
Of course. Now I've got an order.
This one's very quick. Hey, Dr. Lewis, how you doing?
Hey, how are you?
Good. So mine for the squamous cell carcinoma, just because in our tumor board down here in Florida, to work up for squamous cell, MRI, obviously, but they're using PET scans for everybody. It looks at the inguinal area a little bit better. And if it lights up, it doesn't light up. What I know in multiple studies, it says yes, multiple studies says no, it's a waste of time. What is kind of colorectal side saying about it?
Yeah, the ASCRS text says it's not necessary, and the NCCN guidelines say it's not necessary, but it changes the management in quite a few situations. So certainly if you have a T2 or higher lesion, you should order it, or if you have something locally advanced, order it, or your CT is abnormal. But I think on the exam, I would just say it. I don't think it hurts to say it.
Yeah, just because that's our protocol down here is automatically include the PET scan.
Yeah,
It, it does hurt you if you use it on rectal cancer. So you do not want to do a PET CT on rectal cancer.
Oh, for sure, yeah.
But you could absolutely do it for squamous cell carcinoma, I think. And if you do it or you don't do it, I honestly don't think they're going to, drive you to a corner either way. And it's,
Okay.
I don't think the lack of a PET CT or the performance of a PET CT is going to fail you for that scenario. No way.
Thank you, guys.
awesome.
Yeah, and then the last thing I'll say about that is, is just like regular boards, if the scenarios seem hard and you're like getting asked esoteric questions like what to do the third time they're back or whatever, you probably won. You don't lose a scenario where you're 5 steps in and you don't do the exact thing that the examiner would have done. That's a win. You've gotten through the major points and they're just kind of finishing out the time, dragging you through the end of the scenario because you were probably efficient in your time use. So I think that if you are debating over whether a PET CT is the thing of choice for a multiply recurrent squamous cell carcinoma, you've won.
All right. Thanks so much, everybody.
See you.
Thanks, guys.